Good afternoon, everyone. And this evening of this CGR, this time we are Department of Anesthesia and Pain Medicine and Critical Care is presenting. We are covering this time this pain medicine. It is an important part of this our department. The topic is the percutaneous balloon compression for trigeminal neuralgia and underutilized management modality. This trigeminal neuralgia is a very common, uncommon problem, but it's a very severe neuropathic pain. And this is being treated by neuroanesthesiologist and general anesthesiologist. So this time we are presenting about 50 cases of cohort which has been done in last 10 years. And I invite Professor Dr. Dhruv to start this. Dr. Dhruv, please.
Thank you, sir. So, trigeminal neuralgia is a severe chronic neuropathic pain. And according to the ICSG-3 classification, it is defined as recurrent paroxysm of unilateral facial pain in the distribution of one or more divisions with no radiation. This neuralgic pain has a characteristic pattern. It lasts from a fraction of a second to 2 minutes. It is severe in intensity, and the pain is electric shock-like shooting stabbing pain. It is precipitated by innocuous stimuli like touch, shaving, brushing, chewing, swallowing. Any of these can result in the trigger of this pain. Now, the prevalence is around 0.16 to 0.3% with an incidence of 12.6 to 27 per 1 lakh person years. The highest incidence in the older population at around 50 to 70 years, with in the higher incidence in the female population. Now, there are three divisions. The V1 is the ophthalmic zone, the V2 is the maxillary, and V3 is the mandibular zone. The most common zones involved are the V2 and the V3, that is the maxillary and the mandibular nerve. Now, this disease has a high psychosocial impact because of its chronicity and severity in nature. It is one of the most painful conditions known, and when the attack happens, it severely incapacitates the patient. The patient cannot do anything else. Even between the attacks, the patient will be anxious that the attack may recur sometime. So throughout the day, the patient will be anxious and in a constant state of fear. Now, all this results in severe depressive symptoms to the patient, and the patient is usually in depression. Activities of daily living like brushing, shaving, eating, chewing, anything can result in the trigger of this pain, and the person tries to avoid these daily living activities. And this results in poor oral hygiene and weight loss. Because of all of these factors, patients often have suicidal tendencies, and this disease is also nicknamed as suicidal disease. And there are reports of attempted suicides and committed suicides in this disease. Now, when these patients come to our OPD, we often see that they have incorrect diagnosis. They are often diagnosed as gentle pain. And many times they have a long referral time, 1 to 2 years to 2 to 3 years also. In this meantime, they visit multiple practitioners like dental surgeons, even ENT surgeons. And many times we have seen that they have received various interventions which are not necessarily dental extractions. And they also receive various alcohol injections which provide little pain relief for short duration. So by this delayed referral, they are not able to get the adequate treatment and the adequate interventions which can relieve their pain. All this results in the increased morbidity of all these patients. Now, about the anatomy of trigeminal ganglion, it is located in the Meckel's cave in the petrous part of temporal bone. This is the trigeminal ganglion. Medially, we have the internal carotid artery, the cavernous sinus, the trochlear nerve, and the optic nerve. Posteriorly, we have the brainstem. Superiorly, the temporal lobe, and anteriorly, the three divisions of the nerve. This is the V1, the ophthalmic branch. This is the V2, the maxillary branch, and the mandibular branch exiting from the foramen ovale. Now, the vascular compression due to a superior cerebral artery is the most common cause of trigeminal neuralgia. Other causes are less common but include cerebellopontine angle tumor, multiple sclerosis, schwannomas, meningioma, or facial trauma or surgeries. Now, based upon this etiology, we can classify trigeminal neuralgia into various types. First is the classical trigeminal neuralgia, which is due to the vascular loop compression. Then there is secondary trigeminal neuralgia due to secondary causes like multiple sclerosis or any space-occupying lesion tumors. And then we have idiopathic trigeminal neuralgia, where there is no identifiable cause of trigeminal neuralgia, but the pattern will be same as of a classical. Now, this shows the MRI of trigeminal neuralgia. Here we can see the trigeminal nerve exiting from the brainstem towards the Meckel's cave, and this shows the vascular loop, the superior cerebral artery, in close proximity and also distorting the nerve slightly. This shows a meningioma encasing the trigeminal nerve and causing the pain. Now, how does this vascular loop compression cause the specific pain patterns in trigeminal neuralgia? So, when there's vascular loop compression, it impinges upon the root entry zone of trigeminal nerve, and this will result in demyelination and Schwann cell loss. Now, this results in a hyper-excitable nerve fibers with loss of voltage-gated sodium channels reticulation and a decreased threshold of the nerve fibers. Now, there's a crosstalk between the A beta and the A delta fibers. The A beta fibers are the touch fibers, and A delta fibers are the pain fibers. So, whenever a patient touches or swallows or chews, the A beta fibers get activated, but in return, they also activate the A delta fibers, that is the pain fibers, and the characteristic neuralgic pain paroxysm occur. Now, the management starts with the medical management. The first line of drug is carbamazepine, which is also the gold standard treatment and has been used for decades and is quite effective. In patients who cannot tolerate carbamazepine, oxcarbamazepine is the second drug of choice. Then second line of drug includes baclofen and lamotrigine, and third line includes gabapentin, pregabalin, and even Botox therapy has been tried. Now, the definitive treatment or the real treatment lies in the surgical approach, that is the microvascular decompression. This is the best treatment of choice for classical trigeminal neuralgia. In this, through a craniotomy, the posterior fossa is exposed and we identify the arterial loop and the trigeminal nerve. Then the loop is mobilized and a Teflon pad is kept between the nerve and the artery so that the artery will no longer compress the nerve. And this is the most effective procedure with least sensory loss, long-lasting relief, and best patient satisfaction. But because it is an open craniotomy, it is the most invasive treatment modality for these cases. Now, because of its invasiveness, there is a mortality rate of 0.2 to 0.5%, and there can be postoperative morbidity such as CSF leak, brain infarct, or hematoma. So, therefore, this modality may not be suitable for the older comorbid patients. An alternative to this surgery are the percutaneous techniques. In these cases, through a needle approach, we approach to the Gasserian ganglion, enter the Gasserian ganglion, and we can perform various procedures there. These include the radiofrequency ablation, glycerol rhizolysis, and the balloon compression, which we'll be discussing about. So, in a refractory case of trigeminal neuralgia, when a vascular compression is present and the patient is a young or healthy elderly, we can go for the microvascular decompression. If the patient has comorbidities, we can go for the percutaneous technique, that is the radiofrequency ablation and the balloon compression. However, if there is no vascular compression, that is the idiopathic trigeminal neuralgia, we have no other option but to go directly for the percutaneous techniques, because surgery won't help in this. Now, what type of patients require intervention, like any of the percutaneous techniques? Patient not willing for surgery, elderly patient with comorbid conditions, failed microvascular decompression or gamma knife radiosurgery, and an idiopathic trigeminal neuralgia. So, about percutaneous balloon compression, this was first described by Moulin and Lichte in 1983. They introduced a 4 French Fogarty balloon catheter in the Meckel's cave and performed the compression there under general anesthesia using fluoroscopy. And they reported excellent results with only 12% recurrence over a period of 0.5 to 4.5 years. Now, how does this balloon compression actually act? When you inflate the balloon, it will compress the trigeminal ganglion and injure the nerve fibers. But the main point is that it injures the myelin present in the large myelinated fibers, that is the A beta fibers that mediate light touch. And it will preserve the small fibers, that is the A delta fibers, which mediate pain and temperature sensation, and also importantly the corneal reflex. So it will reduce the sensory neuron output. Whenever the patient will touch or do activities, then the A beta fibers won't carry the pain to A delta fibers, and thus the trigger of the neuropathic trigeminal pain will be switched off. And because the whole ganglion is compressed, it is not selective for any nerve branch. It can target multiple divisions. So when trigeminal neuralgia where multiple divisions are involved, balloon compression is a better alternative. Now, when compared to radiofrequency ablation will destroy both the large fibers and the small fibers. And this can result in loss of corneal reflex and keratitis. So in these cases, the balloon compression is advantageous because you can preserve the corneal reflex and specifically treat the V1 neuralgia, in which the RFA is not a good choice. There are some complications associated with this procedure: facial numbness, masseter weakness, dysesthesia, anesthesia dolorosa, corneal numbness, and diplopia. Of these, facial numbness and masseter weakness are common, but they resolve within 3 to 6 months. Other complications can be present but are rare. Now I invite Professor Mohan to discuss about the intervention procedure of the balloon compression.
Thank you, Dr. Dhruv. Already describing briefly the intervention procedure we usually do with basically this procedure we started in 2010-11 and this procedure we usually do in under general anesthesia. It's we have to use very large bore needle and we have to enter the foramen ovale. So we use general anesthesia and incidence of bradycardia during intervention is quite high. So we usually monitor the patient as per protocol and we keep ready defibrillator, resuscitation drugs, and as it's a fluoroscopy guided technique, so we use fluoroscopic C-arm for this. These are pictures showing the different stages of procedure. When we started this procedure, that was in 2011 as such, that time there was no dedicated kit for PMBC or percutaneous balloon compression, and one kit was available abroad, that was Cook's percutaneous balloon compression kit, but that was not available in India. So we make some stopgap arrangement. We use Fogarty embolectomy catheter, 4 French, and this is a 14 gauge interventional needle, typically used for insertion of catheter, stimulating catheter for spinal cord stimulator. We use this, we modified this, we blunt the tip. It was initially very sharp needle, but with the help of workshop people, we blunted this needle and use this. Nowadays, in 2020, a company has launched this dedicated percutaneous balloon compression kit. It has got short length balloon, then dedicated pressure monitoring equipment, and you can have this needles, trocar, introducer, and stellate. We have recently used this technique, this kit. Coming to this, as for any percutaneous interventional technique, especially transforamen ovale technique, we use this technique described by Hartel, use anatomical landmarks for insertion of needle, and with the help of fluoroscopic C-arm, he positioned the needle towards the entry side of the foramen ovale. This patient we position in supine position, slightly neck extension, and landmark, we used 3 landmarks. We use 3 landmarks. One, this is the entry site for needle, that is 2.5 centimeter lateral to the angle of the mandible. Then the direction needle should be the midline of the zygomatic arch, and if you see from the front, the direction of needle should be towards the mid-pupillary line. As you can see this. And while inserting needle, we have to be careful while inserting needle because of fear of, if you breach the mucosa, oral mucosa, the chances of contamination is always there, and there is chance of meningitis. So we have to always prepare, have to be very precautious, and while inserting needle, every insertion like 1 centimeter, so you have to check the needle insertion depth and direction by fluoroscopy. This is the initial position of the patient. After positioning, we take a scout view in PA view and see that whether the whole of the skull is coming in the fluoroscopic image or not. Once you have that, we tilt the C-arm to the cardocephal view and have a view, it should be like W shape. And you can, this is a mandible, both the mandible can be seen, you can see dent, teeth can be seen, this is the area of maxilla, both sides. And the area of intervention is this. If you can carefully see that even in this image, the foramen ovale is being partially visible. Once you identify, then we make a slight ipsilateral oblique tilt in same view and try to visualize the foramen ovale in this area. This is mentonine arch, and the foramen should be lie between ramus of the mandible and the maxilla. You can see very well oval shaped translucent shadow is there, that is foramen ovale. Once you visualize this, we insert the needle by inserting the tip of the needle at 2.5 cm lateral to the angle of the mouth and going towards the foramen ovale. At each insertion of 1 to 1 centimeter, you have to be careful, take different views of C-arm, fluoroscopy view, lateral and all that. Once you insert the needle, usually we insert the needle 3 to 4 centimeter and check whether the direction is okay or not, or the depth is okay or not. Once we are at the, usually what happens, it's a large bone needle, once you enter the foramen opening, you will have a giveaway. That way we can find out whether we insert, we are near the foramen ovale or not. Once we insert the around 4 centimeter, you always take a lateral view, see the direction of the needle. As you can see in this is a lateral view of the fluoroscopic view of skull. You can see that the needle is, this portion is fattest part of the temporal bone, this dark shadow. You can see this is the anticlinal process, this is the pituitary fossa, this is the clivus. The line, the point where the clivus joins the fattest part of the temporal, that is the line area where you have to direct the needle tip towards it. And for this procedure, we never enter the foramen ovale. We keep just 2 or 3 millimeter from the inferior edge of the fattest part of temporal bone. Once you have this, you insert the catheter. You can see the fine line that indicates this catheter, that is, and we never try to breach the clivus line. A tip of the catheter should be just below the clival line. This is showing balloon shape at various. Once we are sure that we have inserted the catheter at the proper position, we insert. Initial insert we use usually 0.7 to 1 ml of radiocontrast material and always inject the dye in continuous fluoroscopy view. This is the usually oval shape appear. Once you have reached the area of volume of the area, that this slight posterior stenting will be there. This is a nipple. This is classical. Once it's adequate, you can say classical pear shape. The posterior stem is going towards the posterior fossa. This is the ideal image. At this, once you should stop and wait for. Usually, initially we use 90 seconds, but nowadays we are using 120 seconds for. We keep the balloon inflated for 20 seconds. And this usually requires 0.7 to 1 ml of dye, and pressure. Various studies have showed that pressure generated by this is around 1.3 to 1.7 atmosphere. This is the diagnostic presentation. What happens during inflation of balloon? This is the fittest part of temporal bone. You can see the carotid artery. You can see the trigeminal ganglion. Ideally, the balloon should be placed here between the bony edge and the dural cilia of the ganglion. The various positions of balloon can be seen. It's a overinflation of balloon, and the part of the balloon is going towards the posterior fossa. That will cause can create some compression, but most of the pressure is going towards the posterior fossa. So this is not ideal. Ideal is either this or this. This is the most ideal position. Picture. You can see the both the ganglion being compressed, and only nipple of the stem of this balloon is going towards the posterior fossa. This is the ideal. And once we achieve this image, you should always stop. And this cell can have good compression, but rest of that you can see in these both views that balloon is going towards the posterior fossa, that can harm the patient. These are images which shows this is a classical dumbbell shape appearance. This is overinflation of the balloon. This is not overinflation, but slightly more dye has been injected. You can see the nipple is still going towards the posterior fossa. This small video clip was saying that once you insert, I am taking care of not to breach the oral mucosa by keeping the finger inside the mouth. Okay, once you finalize that by different fluoroscope view, we try to insert the catheter. We will insert the catheter. This is the final position of the needle. And this balloon is being inflated. And once we keep that front receptive, we deflate the balloon under continuous fluoroscopy. And one has to be careful while removing the catheter. We have to remove in toto both needle and catheter together. Thank you. I will invite Dr. Vasudha to present our.
Thank you, sir. Good evening, everyone. I'll be presenting today methods and results. We have retrospectively analyzed 60 patients of idiopathic and classical trigeminal neuralgia who has undergone balloon compression in the past decade, that is from 2012 to 2022. All the patients in our cohort had classical and unilateral pain. Their MRI brain did not show any evidence of any tumor, vascular malformation, multiple sclerosis, or any other related conditions. Our patients were reviewed by means of telephonic interview or during their OPD visit. Percutaneous balloon compression is a daycare procedure. It is usually performed under general anesthesia. All our patients had a pre-anesthetic checkup prior to the procedure. They were kept fasting according to standard fasting guidelines. In OT, standard monitors were attached. They were placed supine with a pillow under the neck. An atropine-filled syringe should always be kept ready for prompt treatment of significant bradycardia, which can occur as a complication due to the procedure due to trigeminal cardiac depressive response. Evaluation was done in terms of pain score, complications, effective pain relief, and satisfaction score over a period of 2 years. Pain score was evaluated in terms of numerical rating scale. Numerical rating scale is a 10-point rating scale where 0 denotes no pain, 10 denotes worst imaginable pain, a score of 1 to 3 denotes mild pain, a score of 4 to 6 denotes moderate pain, and 7 to 9 denotes severe pain. Our patients were followed up at 3rd month, 6 month, 1 year, 1.5 year, and 2 year. Complications were noted in terms of messeter weakness, corneal dysesthesia, diplopia or loss of corneal reflex, post-procedure headache, and anesthesia dolorosa. Effective pain, the total duration of effective pain relief was noted, which is defined as more than 50% pain relief from the baseline. Satisfaction score over a period of 2 years was noted in terms of satisfied or not satisfied. This is a graph showing demographic characteristics of a patient. We had more number of female patients as compared to male patient. 57% female versus 47% male. The mean age group of our patient was 54 years. The mean duration of symptom was of 4 years. Right-sided involvement was more than left-sided involvement, that is 77% versus 23%. 63% of our patient had history of previous peripheral nerve block, either in the form of alcohol neurolysis or phenol neurolysis. 35% of our patient had previous history of radiofrequency ablation. However, no patient had previous history of microvascular decompression. This is a graph showing distribution of divisions involved. 49% of a patient had involvement in V1 plus V2 division, that is ophthalmic zone and maxillary zone. 33% patient had involvement in V3 division, that is mandibular zone. 13% patient had involvement in V2 plus V3 division, that is maxillary and mandibular zone. And 5% had distribution in V2 division, that is maxillary zone. This is a table showing number of patients having complete relief, mild pain, moderate to severe pain at various time interval during the follow-up. This is being discussed in detail in further slides. All patients had immediate pain relief post-procedure. At third month of follow-up, 95% of our patients had complete pain relief. That is, their NRS score was 0. 5% had mild pain with a NRS score between 1 to 3. At 6 months of follow-up, 95% patient had complete relief and 5% patient had mild pain. Their NRS score was ranging from 1 to 3. At 1 year of follow-up, 90% patient had complete relief, 5% patient had mild pain, and 5% patient had less than 50% pain relief. That is, the NRS score was more than 5. At 1.5 year of follow-up, 87% had complete relief with an NRS score of 0, 8% had mild pain with NRS score between 1 to 3 years, and 5% patient had less than 50% pain relief. Their NRS score was more than 5. This is a graph showing mean NRS score at various time interval during a 2-year follow-up period. This is the baseline mean NRS score, that is 8 prior to the procedure. After the procedure, the NRS score decreased to 0. There was a plateau phase till 1 year. After 1 year, the mean NRS gradually increased up to 2 years. However, this mean NRS score was in the range of mild pain, that is between 1 to 3. This is a bar diagram showing a correlation between shape of balloon and more than 50% effective pain relief achieved for 2 years. 75% of our patient had pear-shaped balloon, out of which 96% patient had effective pain relief for 2 years. 7% patient showed dumbbell-shaped balloon, out of which 75% patient had effective pain relief for 2 years. 18% patient showed round or oval balloon, out of which 73% had effective pain relief for 2 years. In 82% of our patient, number of attempts required to reach foramen oval was 1. In 11% patient, two attempts were needed to reach the foramen oval, and in 7% patient, 3 or more attempts were required. The maximum duration of effective pain relief was seen till 3 years. The minimum duration of pain relief was seen till 1 year. The mean duration of pain relief was till 2.5 years. The mean duration of pain-free period without medication was 1.5 years. 4 of our patients opted for repeat procedure at recurrence of pain, and 2 patients opted for microvascular decompression. The complications noted were anesthesia dolorosa in 1 patient, transient diplopia in 1 patient, 9% patient reported of headache, 68% complained of masticatory weakness, and 97% complained of facial numbness. Almost all patients experienced some degree of facial numbness, which resolved gradually over a period of 3 to 6 months. This indicates successful damage of sensory component of the nerve, which is also the aim of our intervention, as it inhibits trigeminal neuralgic pain from reaching the higher centers. Masticatory weakness was seen in 68%, which resolved gradually over a mean duration of 4 months. However, 2 patients complained of persisting masseter weakness post-procedure. Transient diplopia was reported in 1 patient, which resolved over a period of 3 months. Post-procedure headache was seen in 5 patients, which resolved within 24 to 48 hours. However, in 1 patient, it persisted for 7 days. She was managed conservatively with fluid, bed rest, and oral analgesics. Anesthesia dolorosa is also known as trigeminal deafferentiation pain. Here, the patient feels numbness in the facial area, but At the same time, he also feels constant severe pain in that numb area. This is a very difficult complication to treat. This was seen in one of our patients who complained of facial dysesthesia and numbness in the supraorbital region. He was managed with anticonvulsion, antidepressant, supraorbital and supratracheal nerve blocks. No other complications were noted. This is a graph showing satisfaction scale over a period of 2 years. 93% of our patients were satisfied. However, 7% were not satisfied at the end of 2 years. Thank you. Now I invite Professor Mohan for further discussion.
When I joined pain management team, I think I joined in 2007 onwards. That time, most of the patient usually get around 20 to 30% patient in our clinic or official pain, and majority of those patients were trigeminal neuralgia. And at that time, we used to offer the treatment offered usually was nerve block, peripheral nerve block, either transcoronal approach or supraorbital supratrochlear nerve block, or rarely we used to perform RFA. And RFA are reserved usually for V2 multiple distribution, especially V2 and V3. And there was some patient where there was involvement of V1 distribution, but we never used to ablate the V1 division. We have fear of exposure keratitis, loss of corneal reflex. And that time, even those patients who received number of repeated blocks, usually the effect was, pain relief period was short, very short, maybe around 3 to 6 months, in some patients around 1 year. At that time, my mentor, Dr. Dureja, used to be in charge of pain clinic, and that he started, we got RF machine and started doing RFA procedures, especially V2, V3. But we rarely used to do with V3 component. And while attending one of the pain conferences in Bangalore, there one of my colleague from PGI, he demonstrated this procedure, percutaneous ballon compression. He had live procedure also and video demonstration also. And then later I discussed with him and tried to incorporate that modality in our clinical practice. And but problem was that during that time we never used to have dedicated kit for PVC. So we make some stopgap arrangement of say using Fogarty catheter and 14 gauge spinal stability catheter insertion needle. And that way we started, and since 2011 we are doing these cases, though frequency of intervention is still low. We are hardly, though we have included 60 patients, maximum probably we have done around 80 patients. And we have found that pain relief in these patients, we have seen immediate pain relief occur in all the patients. The moment you shift the patient to the recovery area, and once the patient recovers from anesthesia, if you ask the patient, check it, no pain, no pain. And usually that time used to keep the patient for overnight. And even in the morning, at that time, patient from intervention to the recovery or to the next morning, patient off the drug. He was not taking any oral medication. That shows and we never used any local anesthetic during intervention. So probably that was the effect of compression only. And we followed for 7th day, 15th day initially, and there was no change in most once the patient pain relief, there was no change in pulse score. And the average pain score in our series lasted for 2.5 years. It ranged from 1 to around 3 years. But I have my personal experience that even one patient came after 4.5 years also. And the beauty was that this patient, I offered him other intervention like RF and all that, but he insisted I will go for same procedure again. And he underwent this procedure. Regarding what the literature say, even the previous literature says that effective pain relief after this intervention between 90 to 90% patient is as good as RFA, radiofrequency ablation. Similarly, there is a relationship between duration of compression and shape of the balloon. In most of the study, they have found that if one can achieve pear shape, that is the maximum relief and good outcome. Because in pear shape, what happens is that this balloon compression is restricted by bony edge and the dural sheath that covers the ganglion. If you inflate more, part of the balloon will migrate towards the posterior fossa, and if sometimes there is no space, actually the space of the Meckel's cave depends on patient to patient. Some patient may have more, some may less. So if we can achieve this shape or this shape, those patients have maximum pain relief. And in other studies also, they have found that similar type. And sometimes in anesthesia, we tend to increase more volume. That's the problem, that patient may migrate towards the posterior fossa. Is of no use. So always the balloon should be placed in the porous trigeminal, and radiologically, how can we find? The tip should never cross the clival line. And sometimes we experience irregular shape also, but that is because of analytical variation of Meckel's cave. And sometimes the patient who have repeated injection, especially in olden time, patient used to have glycerol injection or phenol or that alcohol injection. That was very rare. That causes adhesions in the Meckel's cave area. So in those patients, we can have irregular shape. The irregular shape is not a problem unless, as long as that balloon is within the porous trigeminal. These are different shapes of the balloon we encounter. This is a dumbbell, this is a pear shape, this is the classical oval or circular shadow. Still that balloon within the porous trigeminal. In our practice, we use the 4 French catheter, and the volume injected is 0.7 to 1 ml, and we keep the inflated balloon for 120 seconds. In clinical literature also, usually initially that Mulanal very first study, they inflate the balloon for 3 to 10 minutes, but later on most of the investigators use 1 to 2 minutes. We also follow the same dictum, and the study they found that if blood in those studies where they have monitored the balloon pressure, they found that if pressure achieved is less than 600 millimeter mercury, that this therapeutic is not so much. For effective pain relief, the pressure should be more than 1.3 atmosphere, that is around 1000 millimeter mercury, and usually the pressure achieved in most of the between 1.3 to 1.7 atmosphere. And initially some investigators use small duration of compression, that is like 60 to 90 seconds. Even the Lutheran, they use 3 to 10 minutes, but later that people have found 1 to 2 minutes adequate, and some investigators try to inflate the balloon for 60 seconds, but though it limits that cardiovascular vascular instability, but compression was not adequate to provide the effective pain relief. Similarly, one of the major problem in this is that once you insert the needle foramen ovale, even the touching of mandibular nerve by tip of the needle can cause bradycardia. And some patients in those can have severe bradycardia. And in Western literature, most of the time the investigator use defibrillator or pacemaker leads or pads before conduct of this procedure. In fact, the appearance of bradycardia is convinced that we have entered the foramen ovale. And in our series, 100% patients have, once you touch and try to enter the foramen ovale, 100% of the patients have bradycardia. Either you have to stop or you have to give some atropine and wait for. As Dr. Vasudha is saying, facial numbness, almost all the patients will have facial numbness, but most of the time this facial numbness will regress for a period of time. It will not last more than 3 to 6 months. Masseter weakness is another problem with the procedure, but it's also transient, and usually patient recover very well within 3 months. And unfortunately, in our series we have one diplopia, that is because of trochlear or probably nerve compression. That is maybe because of some overinflation balloon and migration of balloon towards the little valve of the. And another unfortunate, this is anesthesia dolorosa, a very severe and troublesome problem for the patient. Still, that patient is being followed up in a clinic, and we have attempted number of therapeutic measures like pharmacotherapy, different nerve blocks. Especially, he is having problem in the ophthalmic division, and we have attempted number of, but effect is short lasting, and we do offer him another clinical modality for management of such patients, that is percutaneous stimulation, but because of economics, that is not possible in that case. And there are incidents of subarachnoid hemorrhage report, especially in those patients where in overenthusiasm you try to insert in the foramen going towards the posterior fossa. The chances are and tearing the dural sheath of the ganglion. And this procedure as such have very small morbidity and mortality. And in literature, only 1 or 2 patients have died because of this, because of inadvertent vascular injury and causing this. Even in literature, diplopia do occur in some patients, and it's a transient and resolve over a period of time. This is the data that the balloon compression, number of stage 5, total number of patients. This you can see that mean duration with this is 10 years, almost 4 to 2. But in our series, we have average duration on 2.5 or maximum on 3.5 or patient 4.5. In this series also, they have compared this number of patients and 55, and facial hyperplasia around almost 20% patient have this, corneal hyperplasia 5, and motor weakness 34 patient out of 75, that's less. But we encountered much more than this complication in our series. This is a recently published study from Indian Journal of Pain, and they have compared number of intervention balloon compression, and that effective pain relief initial is 87 more than in one series is 53%, but 58. But in our series we have around 95% of the pain relief, initial pain relief, and side effect profile itself is not much less, not from high. But in PBC you can see that 85%, 89% over 3 years, then over 82%, 69%. And in our series, we have around 90% 5% pain relief, and average pain duration, relief duration was 2.5 years. The same series, all of these studies have shown that good pain relief in most of the patients. And coming to recurrence rate reported is on 20 to 30%, and 5 years is 20% in one of the series, and 10 years is 28%. Effectively, you have recurrence after rate of around 20 to 25% in most of the series. A limitation of this study, what we encountered is one is no availability of dedicated kit, so you can't monitor the pressure, and important that's supposed to be influencing the outcome. But in our clinical, we found that if you can achieve effective pear-shaped balloons and duration is around 120 seconds, that outcome is very good. We have around 95% patient have good pain relief. Another problem is that patient requires general anesthesia. Some patient may refuse to undergo general anesthesia for intervention of trigeminal neuralgia. In those patients, other can be offered. And initially, no proper balloon compression was, now it's available in India. And these are the comparative, like RFA can be performed under sedation, and as patient has need to report the electric stimulation by targeting the nerve, but some patient don't like to be, and inserting needle in foramen is very painful. Once you touch the nerve, patient will cry like anything. In those patients who don't want any intervention in local anesthesia, this can be offered, and patient will be comfortable will be in general anesthesia. And one of the problem with RF is the loss of corneal reflex, especially for V1. Even if you have stimulated the V2, V3, there is chance of compression, ablation of V1 component. They lie very near. The chance of V1 ablation is always there. So that in those patients one can have loss of corneal reflex, causing exposure keratitis. In those patients, this technique can be used very well. And localization of specific dermatome is by stimulation is required. Here you don't require any stimulation. And in this, there is higher incidence of dysesthesia. But here, incidence of dysesthesia is not so common, but masseter weakness is almost 64% of the patients do have masseter weakness, but those patients recover very well over a period 3 to 6 months. Just to summarize, percutaneous balloon compression has the management modality of trigeminal neuralgia and effective procedure with minimal complication, and it can be safely used with involvement of ophthalmic division, and it's a very good intervention technique for patients who have number of failed intervention and not responding to them. Even those having intractable pain and failing to respond with pharmacotherapy, have some complication, this modality can be offered very well, and it works quite well. And especially in those patients who are waiting for MVD, like patient with classical neuralgia with some conflict, neurovascular conflict, those patients who are waiting for MVD or reduced surgery, or in those patients who don't have any facility for MVD reduced surgery, that can be offered, and those patients can be referred to a pain physician, and this modality can be offered. And just to note, it improves the quality of life of the patient, as the patient is pain free most of the time, and average duration of pain free in around 2.5, as in reduces said, pain relief will last for 10 years also. Thank you for.
On the behalf of Head of Department, Professor Lokesh, I would like to thank Dr. Mohan, Dr. Dhruv, and Dr. Vasudha for a wonderful presentation. Its technique is seems to be very complex, but you still properly made it easy, and that's why your success is was very high. Any question or comment from audience? You might take that. Yeah. Dr. Arvind.
Thank you, sir. Thank you, Dr. Dhruv and Professor for this wonderful presentation. It is definitely, sir, it's a very complex procedure. In our department, I think once we tried it, I think Dr. Arvind can tell you better. That was by Dr. Saini. But the patient didn't have good outcome. After that, we stopped doing it. We are not doing it. I have a couple of questions based on the presentation. Like Vasudha presented, you also mentioned, sir. The masseter weakness is around 68%. Is it something to do with this procedure is carried out under general anesthesia so that you can restrict the duration of compression, or only specifically target sensory components so that this problem doesn't happen? This is one aspect.
Thank you. Very good question.
Is, one more question. You said the indication includes V1 division, means involvement of V1 division. The radio frequency, obviously, it will call corneal anesthesia. Are you still doing visceral bisepotomy? If not, if you are doing it, there are other cases also where not only V1, the other components were involved. So, what was the indication of going up? So, 3 questions.
Thank you. Actually, as far as first question is concerned, if you know the anatomy, if you recollect the anatomy of this sensory component of trigeminal ganglion is totally different entity, and the motor branch, that is V3 division for motor, that runs just inferior to the, while coming out of the Meckel's cave, come inferior to the, and we position the catheter in such a way it's inevitable to compress this also. That's why chances of motor weakness, compression, causing loosening of ischemic changes in the motor division high. That's why the incidence of muscular weakness around 64 to 60. In some series, even 80% muscular. But the beauty is that it's a transient compression. Initially, the patient will have motor weakness, but over a period of time, we experience following those patients that motor weakness gradually decreases and patient becomes normal after 3 to 6 months. Maximum the patient can have muscular weakness of 5 to 6. Initially, the patient may experience a problem with muscular because while chewing, there will be bite, teeth bite, the mucosa out of the, that is, but usually those patients tend to develop eating habit, like they use the contralateral side initially, and that's why initially the patient may feel bit troublesome for the patient, but usually patient cope very well with this, and the regression or the recovery of motor weaknesses which occur within 3 to 6.
The other aspect is asking what are the indications for other divisions involved. Means
I couldn't get you.
Means there are V1 is the indication. Patient
So for any procedure, V1 involvement, this can be used. That's why we told in refractory patients.
that's a very means in US series, the target was to patients who are having V1 involvement because of obvious reasons. But what was the reason for V2, V3 in other cases? Yes, sir, you have done it, or was there any indication?
Initially, we try to include only those patients who have V1 involvement. Okay. But for any intervention, what we offer is we offer the patient. Okay. In some of the patients who don't require any needling while awake, they want sedation or GA. In those patients, we include those patients, especially multi-division involvement, B2, B3, and severe, and especially those patients who have underwent number of RFA procedures. RFA procedure can also fail. Even MVD procedure, one of the patient has MVD, this gamma knife. No? Gamma knife, in this patient we offer this and he accepted. Patient acceptance, patient willingness to undergo this intervention very well. And even if you offer the patient and even V2, we have included V2 and V3 also, not the V1 or it. That is not a contraindication of. Only V1 is not, you should do this procedure. In most of the series, even the investigator have done V3 division.
So in that condition, how do you define in these patients you should go for radio frequency, and in these patients you should go for balloon?
So in most of the patients, we offer this intervention. Only patient have refractory to the pharmacotherapy, patient have involvement of V1, patient have undergone number of RFA intervention where the effect is short-lived. Like sometimes some patients have come after 3 months or 6 months. Okay. Radio frequency is the problem is that ideal location, ideal placement of the needle tip is very important. And the failure rate of RFP is always there. Okay. And if you are not using the proper, like in fear of ablating the V1 division, sometimes what the clinicians use is they use very small tip, active tip, like 2 millimeter or 5 millimeter. In fact, if you use small tip, there is a partial ablation. Those are the patients we have short relief or no relief at all. In those patients, we can offer this volunteer.
Are you still practicing glycerol radicals?
Glycerol, I just seen Dr. Das doing one. That is very troublesome patient. The problem is there is no control of spread of. Okay. And in those patients have to be kept in kneel down position, keeping the head flexed for number of minutes. Okay. That is, and there is no control of spread of the drug. And if the drug glycerol goes towards the positive forces, and another is that you have to breach the dural barrier. Okay. The amount of CSF you will take out has to be injected in form of same volume has to be injected in glycerol. Okay. So you are reaching one. Basically, that's a pain relief. Usually, the patient if pain they can go for this patient, but now it's not used. Any alcohol, phenol, glycerol, that is out of question. Even in clinical practice, I told you that when we started this, when I joined as a pain clinician in our department, pain clinic rather, then most of the clinicians, Dr. Dureja, Dr. Bhalna, they used to perform transcoronary or supraorbital circulatory. The problem is that patient, I have seen number of patients who have come back. I have followed the patient who have received around 40 injections of this, okay, with very short-term pain relief. And in those patients, the character of pain becomes so severe, so annoying, then even if you offer other type of modality, that patient won't respond. Only treatment of choice remains the peripheral nerve stimulation. Even this balloon compression usually not.
Just a small comment. This one diagram nowadays we are also not doing. I don't know, even things will agree with me. Dr. Saini has given blocks in some of the patients. After 10 years, 12 years, those patients are good. I don't know how long.
Anyway, I don't have any experience to kind of comment. I'm quoting from the literature only. Okay. I don't personal experience of doing glycerol therapy. What I learned from Dr. Chaturvedi and Dr. Das, and effect will last for years together.
Like yesterday, in the fellows, you can go through an article where after 10 Sarisi practicing Martinez. He has a series of 483 cases, and that is published probably in Pathogenesis.
No, way back.
Long back. It's just for academics. Thank you, sir.
One of the I want to stress is clinical practice is evolving. Okay. Like when I joined as SRJR, I used to listen to one lecture on myasthenia gravis. Okay. There, the clinician tend to use 1/10 of the muscular system. Scoline. Don't represent. Okay. In my clinical practice, and most of the clinicians may agree, that requirement of muscle relaxation is as good as normal healthy patients. So this clinical practice is always evolving. New technique comes, old become. So why you could go back? You have neuromodalities, you have stimulation technique, you have PMBC, you have RFA, and in my opinion, and most of you agree that one should not perform this nerve blocks repeatedly.
Thank you, Dr. Mohan and Dr. Krishnan. You have shared your experience with us. I am sure Neuralgia is a pioneer in starting treatment for trigeminal neuralgia. Same followed by Dr. Dash. They have definitely had series, but I think that as time evolves, the technology evolves. Most of the things are based on the technology. Arvind, thank you for coming. I have one question, sir. That shows us a lot of bradycardias. Is there any treatment for bradycardia?
Most of the patients do require bradycardia, even if remove or slightly change the position of tibial needle, it's a reflex bradycardia used to. But once you start inflating balloon again the patient will have. So it's better to give some atropine. And initially, as we go by literature and all that, when these pads were available, temporary pacing pads, I kept the pad in around 5-6 patients, but pacemaking pad. So, but you only require atropine in patient response. And in one of my patient have near straight line, but he responded well to it. Pump. No. The role of prophylactic, actually what happens is, this is the way of finding we are under the coronal vein. That shows it's tip is right in the foramen.
Thank you, Dr. Mohan and your team, and thank you, audience. Thank you.